coronary endarterectomy on long-term anastomotic remodeling independent of graft type used. Before I go to the main article, I will start with some basic details regarding vascular anastomosis, highlighting coronary anastomosis. So, a vascular anastomosis is an anastomosis between two vessels, a graft, usually without disease, and a host, usually with disease, but it can also be between two grafts or two hosts. These graft and host vessels can as well be arteries or veins, as well as biological or prosthetic material. Dr. Carrel, in 1912, the Nobel Prize winner, introduced in 1902 the vascular anastomosis procedure and proposed a triangular shaped anastomosis. He started the anastomosis by distributing three separate sutures between the two vessels, each at 60 degrees of the anastomotic circle. The triangulation was proposed to look at and oppose correctly the margins of both sides of the anastomosis. He continued in everting the edges of both anastomotic margins to avoid the contact of blood with any other surface but the endothelialized inner surface of the vessels. To conduct a successful coronary anastomosis, some basic essential principles are...
You should have put a diagram of the Carrel's technique, which is important, and that was the basis of all vascular anastomosis. He initially started it for transplant experiments in the animals way back in 1902. I wish you had put that diagram. Okay.
Yes, sir. So the essential principles are: first is avoid any manipulation of the endothelium. Second is use both hands for a surgeon. For a right-handed surgeon, the left hand provides the exposure while the right hand places the suture. Ensure the full range of motion 360 degree of the needle in the needle holder to allow the adequate angulation. Sutures must follow a path that goes from inside to outside in the coronary target. Needle repositioning must be completed in proximity to the anastomosis and after each pass of the needle. Spacing of the suture must be homogeneous and consistent. Always to use a parachuting technique. Finalize the construction of the anastomosis on the surgeon's side. Never to tie the suture at the heel or at the toe of the anastomosis. Always unclamp or inject the graft while trying to avoid purse-stringing the anastomotic suture line. In the technical criteria of an anastomosis, the coronary anastomosis performed in bypass surgery.
Slide didn't move. Okay.
The coronary anastomosis performed in coronary bypass without the support of an extracorporeal machine has the same criteria as the one performed with the support of CPB. But in addition, it needs to be adapted to three additional criteria. In off-pump surgeries, there is very reduced air space, there is angulated perspective in relation to the heart, and the anastomosis performed on an unstable or beating surface. The optimal anastomosis is the one that provides very long-term patency through minimal wall trauma and wall stress and an optimized internal flow. In sequential anastomosis, it will be important that the anastomosis creates no negative effect on the further flow downstream in the graft. Several authors have tried to bring numerical analysis, computational flow dynamics, and modeling to identify the optimal technical anastomosis. But a vascular anastomosis is always at a risk of intimal hyperplasia, restenosis, and an early occlusion. regarding the wall shear stress WSS. The importance of wall shear stress in anastomosis, its technique and precision is very important. Wall shear stress in atherosclerotic progression, it poses a very risk factor. While low wall shear stress can cause plaque buildup, necrotic core growth, and constrictive remodeling. While in high wall shear stress, the calcium buildup, the fibrotic tissues regression, and expensive remodeling chances are more. So, the ultimate goal is to avoid either very low wall shear stress or very high wall shear stress zones. The figure describes the various wall stress exerted on the vessel wall. Among the different stresses acting on the arterial wall, the tractive force induced by the blood flow on the endothelial cell surface is called the wall shear stress. The wall shear stress distribution by the location. This wall shear stress varies according to the place of measurement. At outlet bottom, higher wall shear stress is observed in longer anastomosis like end-to side anastomosis. At inlet bottom, the diamond-shaped designed anastomosis shows the highest WSS. At inlet top, the wall shear stress is lower in diamond and even lower in parallel type of anastomosis. At outlet top, it is highest in diamond, then parallel, and then lowest in end-to side anastomosis. The higher the energy efficiency, the smoother is the blood flow. So the optimal end-to side anastomosis for an end-to-end anastomosis length can be taken as approximately 6 mm, which provides the highest energy efficiency. How to minimize vessel wall trauma in coronary anastomosis? Some basic practical things are needle handling tips. It is said that better to use the unlocked needle holder to minimize the penetration trauma. And this kind of needle holder is best in beating heart situation to accommodate a micro movement to avoid any kind of micro puncture. Another basic thing is choose the smallest needle body. The Sabeno needle, which provides a cross-sectional breadth of 250 micrometer, while 8O it's nearly 150 micrometer. Even 1 millimeter drift can cause 1000 micrometer of micropenetrating trauma. Surgical training is that's why mandatory to reduce the drift during coronary anastomosis. Stitch frequency and bleeding risk. Standard spacing in general is taken as approximately 1 millimeter between the two sutures. Even the too few suture lines can impose the bleeding risk, while too many of suture line can cause unnecessary trauma, risk of progression of the disease. So that the balance of trauma and hemostasis is carefully achieved. Some basic practical suture technique essentials are place sutures on the both edges of the anastomotic surface. Bite distance from the edge can be nearly 1 millimeter, but the edge fragility to be considered during to take the distance. One important thing is to ensure the eversion. The Carrel's principle is that eversion to achieve a everted edge such as to oppose the inner endothelial cell layers. These two layers get opposed to each other. Another, the opposite of this to avoid any inversion which may cause turbulence or occlusion. Radial distribution for optimal wall shear stress. As described in the figure, the radiary positioning of the suture points is depicted. The optimizing the anastomotic flow with the radial suturing, it distributes the suture radially, requires continuous adjustment of the needle angle, reduce air space, complicates this technique. But it definitely improves the flow dynamics and shear stress balance. In case of diseased vessel anastomosis and some other general consideration we can follow, technique with atherosclerotic vessel. In case of atherosclerotic vessel coronaries, in general in any coronary, stitch should be strictly from inside to outside. This kind of stitching will prevent the plaque dislodgement to the distal coronaries. It minimizes the risk of distal atheroembolism. So tailored approach to the vessel pathology during anastomosis should be followed. Knot quality is very important. It should get strictest attention. The key points are exaggerated tension on knots can cause the visible excavation of the graft. Proper knot is a cornerstone of any durable anastomosis. How the incision in the host vessel, whether it is parallel or diamond shaped, the geometry of the anastomosis can take different pattern with different effects. It is possible to just incise or excise a section, but in coronaries, excision is rarely done due to the reduced size of the vessels in coronary surgery. The exception could be a small or unexpected plaque at the site of incision or a previous anastomosis as in redo coronary surgery. The incisions in the vessels, the host vessels. Usually it is an incision in both vessels. Here, two major possibilities exist. Either the incisions are parallel in three-dimensional space depicted in figure A, the most left diagram. This is usually done when the both vessels are in the same axis. If the vessels are in a perpendicular axis versus one another, then this solution doesn't open the anastomosis. The lower diagram depicts this situation B, but it creates a natural tendency towards approximation of the anastomosis axis. So the alternative is the diamond-shaped anastomosis, which is depicted in C. Here both vessels receives an incision in their axis. So in the creation of the anastomosis is pulled open as depicted in figure E and F. The risk is that if one or both incisions are too long, the anastomosis is then pulled open too far and the cobra head is flattened. Therefore, the 6 mm rule is not valid in case this here anymore, but any incision of one of the two vessels will never exceed the width of the smallest of the two vessels. Matsuura identified that the parallel anastomosis provided more flow to the native outlet and the diamond-shaped anastomosis provides more flow to the bypass outlet. The diamond-shaped anastomosis issue is valid for a single as well as sequential anastomosis. Parachuted or non-parachuted anastomotic technique. In a parachuted anastomosis, the graft is presented at a distance from the host and the first suture is placed with a distance between the graft and the host. After some sutures, both components are approximated. This parachuted anastomosis demands airspace. With modern off-pump CABGs may not offer that adequate airspace, so at least it can.
The slide has not moved. You're still on incision. No, you are okay.
This parachuted anastomosis demands airspace. With modern off-pump coronary artery bypass surgery may not offer that airspace, at least not without any hemodynamical consequences. Though this parachuted technique is generally practiced, it is deleterious at the microscopic level for the graft and the host wall due to the giggly trauma when approximating. Therefore, the parachuted anastomosis has been replaced nowadays with a non-parachuted version, demanding minimal airspace, even less than 1 centimeter. But it demands superior needle control to reach the different radially positions. In case of sequential grafting in CABG, what are the techniques and consideration? Strategic planning is crucial, which requires both preoperative and intraoperative planning. The mandate is not one size fits all. So we have to adapt to the anatomy and also the conduit availability. We must be prepared to improvise in case of sequential anastomosis. Like in example, in case of unexpected short graft length, in case of difficult targets, the sequential anastomosis is a better option. Some general techniques, I'll describe some basic techniques, which the epicardium should be incised with a 15 blade knife. The arteriotomy length usually varies from 4 to 5 millimeter. The graft pressurized with syringe or bulldogs. The opening of the graft, it uses the beaver's blade. It should be taken into the consideration to avoid any kind of deep penetration. Don't cut through the back wall of the coronaries. Suturing technique. It starts at the toe of the conduit. In case of conduit, should be outside to inside. While on the coronary arteries, it is inside to outside. Ensure matching the incision lengths on the graft and the artery. To maintain the low pressure flow through the graft during tying to avoid the pus stringing effect on the anastomosis. Before conducting anastomosis, the adhesions and the fascia should be adequately removed. Already we described that the epicardium should be incised with 15 blades, while the 11 number blade 30-degree or stab knife is used for straight arteriotomies. Usually for the arterial grafts, we use 8-o-proline suture, while in case of venous or radial artery graft, we use 7-o-proline sutures. What are the take-home points? To be versatile with anastomotic options, to prevent kinking and tension in the anastomotic line, use precise incision and consistent suture technique, maintain a low pressure flow during knot tying to avoid the pus stringing effect. Types of the anastomosis in sequential grafting. The lateral or diamond-shaped anastomosis, usually used for the intermediate targets like diagonal. T-shaped or anastomosis, usually for the distal targets. Termino-terminal is usually to extend the graft when the length is insufficient. The basic is to match the geometry of the conduit and target for an optimal flow in the anastomosis. The lateral anastomosis. The lateral anastomosis, side-to-side anastomosis of graft to coronary artery. In sequential grafting, it is commonly used when the lemma is anastomosed to diagonal, then to LAD. So lemma to diagonal branch of the LAD, the side-to-side anastomosis is performed. It is avoided when the coronary targets are too close together. It is preferable to use a diamond-shaped or baby Y graft instead. The key consideration in this lateral anastomosis, it ensures the sufficient graft length. It avoids any acute proximal and distal angles. Any proximal or distal angulation should be avoided. consider sequential targets to avoid any kind of tension or twist in the anastomosis. The right hand side, the figure shows the outlay of the side to side anastomosis or lateral anastomosis. The diamond shaped anastomosis. It is usually used in lateral, posterior, or inferior walls of the heart. The conduit must stay perpendicular to the coronary arteries. The advantages are it reduces the risk of kinking. It enables the multiple distal targets. The key steps to be followed in diamond-shaped anastomosis is the coronary arteriotomy. It should be approximately 20% shorter than the graft opening. The anastomosis starts at 3 o'clock position on the graft, proceed it to the toe and heel. It is important to maintain the 90% geometry, that is the Latin cross geometry. Avoid any kind of flattening during anastomosis. The distance, as depicted in the figure, we can see that the distance between BC and DC must be always less than AG to CG. T-shaped anastomosis. It is usually used in right-sided anastomosis like PDA revascularization, especially when doing from the left side. Also can be used for both PLV and PDA sequential grafting. Techniques are coronary arteriotomy should be approximately 20% smaller than the graft diameter. The starts as toe, proceed to the posterior wall along the backhand, and anterior wall to be taken as forehand. It is important to ensure the alignment of the graft and the artery wings, which is the same the Latin cross geometry. Terminolateral anastomosis. It's the most common and easy anastomosis for coronary surgeons in sequential grafting. The length of the coronary incision should be approximately 3 times the diameter of the coronary artery, and the size of the graft opening is 1.5 times the size of the coronary incision. It is the exception in compared to the other anastomosis. It started on the left side of the conduit, 2 bites away from the heel, following the standard outside to in path for the needle. A corresponding bite is taken on the left side of the coronary artery, 2 bites away from the heel, with the needle passing inside to outside. Then the anastomosis is completed in a running fashion along the right side of the coronary arteriotomy and up along the right side of the conduit until 1 bite from the toe of the arteriotomy. The right side figure depicts the terminolateral anastomosis. Terminal anastomosis, when the conduit length is insufficient, it joins conduit A and conduit B. The 2 parts of the conduit can be joined. The construction is it uses the 2 7-oproline or 8-oproline running sutures. In the conduit A, the needle passes from outside to inside, while in conduit B, it passes the reverse from inside to out. Using 2 suture arms, the aim is to prevent the pus stringing by using 2 suture arms running from heel to midpoint on each side. It is important to for a clean anastomosis that the conduit remains untwisted and unpressurized. The epicardial incision is clean. Incisions matched in length and shape both. To maintain a gentle loops to avoid the pus string effect, use as a good assistant to stabilize the conduit. Now, coming back to the main article, The reviewed article I am going to present is only grafting with or without coronary endarterectomy, which maintains the long-term favorable anastomotic remodeling regardless of the graft material used. The article published recently in 2024 in the Journal of Thoracic and Cardiovascular Surgery. The short-term result of the same article, which were published in 2019 in the Journal of General Thoracic and Cardiovascular Surgery, both the articles are available in PubMed Central and also available in Springer Nature. The authors are same, Minato and Okada, the Japanese authors. This is the preview of this article. And this is the older article published in 2019, the same study with the short-term outcomes. What is the background of that article? The problem encountered in diffuse coronary artery disease. The standard CABG techniques is very challenging when the vessels are diffusely diseased due to the lack of a suitable anastomotic sites in patient with diffuse CADs. Surgical angioplasty with or without coronary endarterectomy is one option to achieve a complete revascularization better than the lesions which are not amenable for multivessel PAs. History of coronary endarterectomy. The coronary endarterectomy was first introduced in 1957. It involves the blind removal of a calcified plaque through a 1 to 1.5 centimeter incision approx. However, the incomplete removal of plaque and residual debris always increases the risk of thrombotic occlusion in coronary endarterectomy. We know that there are two types of coronary endarterectomy. One is closed method and one is open method. In closed coronary endarterectomy, it performed with a simpler anastomosis without full visualization of the coronary, the lumen. It commonly used for LAD and right coronary artery. While in open coronary endarterectomy with only grafting, it involves a long incision over the diffuse lesions, allowing a direct vision of the disease through the lumen. It is more technically demanding and time-consuming due to the long anastomosis process. Currently, the current preference is due to the complexity. Closed coronary endarterectomy with simpler anastomosis is often preferred in clinical practice. The gap in the lacuna in the literature prevails that the most previous studies have focused on closed coronary endarterectomy. There is limited research on the long-term angiographic changes in only anastomosis, especially when it involves with an open coronary endarterectomy. Purpose of this study: to retrospectively evaluate the following in only grafting with or without coronary endarterectomy, either in the term of long-term clinical outcomes, graft patency, or remodeling capacity of the anastomosis. Only grafting was performed across all coronary territories using various kind of grafts, either it's internal memory artery, radial artery, even the gastroepiploic arteries were used, and always saphenous vein were used. The 110 patients underwent bypass surgery with only grafting from 2001 to 2021, which were included in the studies. After excluding 2 early MI death in the patient, total 108 patients were included. The mean age of the patients were 68.4 years. 43 grafts included coronary endarterectomy, while 84 grafts used only the only technique, not with endarterectomy. The mean follow-up was 102.8 months, which comes approximately 8.5 years. Early outcomes of 95 patients in this group were previously reported in 2018, and the current study includes the long-term outcomes of those patients. The design of the study is retrospective analysis across 2 centers, 2 hospitals from Japan, 36 patients from Fukuoka Hospital from January 2001 to November 2008, while 72 patients were from Kansai Medical University from May 2009 to April 2021. Only grafting decisions were made primarily based on the preoperative coronary angiography and coronary CT finding. The criteria for only grafting included either inability to perform a standard anastomosis due to diffuse lesions, multiple stenosis in the same artery with large branches like septals, stenotic plaque at the intended anastomosis site, even if it is short, long calcified lesions along the target artery, restenosis or occlusion of a distally placed coronary stent. Coronary endarterectomy uses the criteria for endart was the preoperative CT finding of a long calcified lesions, which helped speculate the need for coronary endart. Coronary endarterectomy was performed intraoperatively also if the calcified intima media spontaneously separated during arteriotomy. The arterial wall was too hard to penetrate with a needle. Closed coronary endart was discontinued due to the poor outcome. One in 3 patients, there was poor outcome in terms of patency rate. The risk factors for coronary artery disease patient, total 108 patients are the risk factors are the characteristic of the patients included were the mean age was 68.4 with a plus minus of 9.5 years. The male is to female ratio were 87:21. Diabetic 71 patients, 93 patients were hypertensive, 73 patients had deranged lipid profile with a smoking history of 64 patients, while 17 patients has CKD. Among the 79 were on hemodialysis. Peripheral arterial disease were present in 20 patients. Cerebrovascular stenosis, CV associated more than 75% is 34 patients. Old cerebral infarction is 14 patients. Previous coronary intervention in terms of stenting was in 36 patients. There are no previous cardiac surgical patients. Unstable angina, 24 patients presented. Acute MI, 6 patients presented. Old MI, 57 patients had old MI. 42 patients were left main patients. The triple vessel disease were in 89 patients, while the double vessel disease was 15, with a critical single vessel disease in 4 patients. Low EF less than 40% were 21 patients. Preoperative IABP used in 11 patients, while emergency CABG were performed in 8 patients. The surgical procedure, the only grafting with or without coronary endart was performed after completing the distal anastomosis for other coronary targets. This sequencing was done to ensure blood flow to the vital areas before initiating the more complex grafting on diffusely diseased vessels. The procedure was smoothly conducted on a beating heart mostly, not using any cardioplegic arrest. The approach aims to avoid risk associated with cardiac arrest and cardiopulmonary bypass, unless it is absolutely necessary. The decision to operate off pump without CPB or on pump with CPB was based on expected length of the arteriotomy. If it is too long, the presence of any comorbid heart disease. Early practice criteria. If arteriotomy length is less than equal to 2 cm, off-pump procedure was chosen. If arteriotomy length is more than 2 cm, on-pump procedure was selected. These decisions prioritize patient safety and control during technically demanding parts of the surgery. Once procedural safety was well established, the team shifted to primarily off-pump surgery to minimize bypass-related complications. Exceptions were where on-pump surgery was still used, either case requiring coronary endarterectomy along with previous occluded stent removal due to higher complexity. Long-only procedures handled by an inexperienced surgeon to improve the surgical control and reduce risk. The one major thing was to use the segmental clamp and distal perfusion methods. The method allowed controlled clamping and continuous distal perfusion during the anastomosis, which ensured the ongoing blood supply to the rest of the myocardium, which minimized the risk of intraoperative myocardial injury. The figure depicts the procedure for coronary endarterectomy with segmental clamp and distal perfusion through an external shunt cannula. In figure A, we can see the number 1, that proximal coronary incision, which extending distally 2 to 3 cm. The number 2 depicts the distal perfusion through an external shunt cannula. The number 3 on the both sides, it depicts the proximal and distal snare clamp placement. The number 4 is the endarterectomy of the proximal lesion under direct vision. The second stage, the depicted in figure B, is the number 5, which shows the long anastomosis of the proximal graft on both sides of the artery. Number 6 is the transfer of the proximal snare clamp on the onlay area. Number 7 is the opening of the graft to perfuse the proximal portion. The opening of the either lima or whatever graft is used to open it up so that the proximal portion get perfused, which is depicted by white arrow. Number 8 depicts in the figure that the extending the coronary incision distally until a normal intima appears, and the repositioning the distal cannula more distally to achieve a distal perfusion. Number 9 shows the repositioning of the distal snare clamp more distally. Number 10 shows that the onlay anastomosis is completed, followed by a distal endarterectomy. I have a small video regarding the procedure. Try to play. This is the procedure. The left internal thoracic artery to LAD onlay anastomosis plus coronary endarterectomy. Because of an occluded LAD lesion, the distal portion of the LAD is incised. A distal perfusion cannula, as shown, is inserted. The proximal, the anastomosis of the proximal part is being extended until the incision cannot locate a continuous lumen. Then the proximal portion of the calcified lesion is incised. The endarterectomy is being performed proximally. You can see the severely calcified the proximal portion. Then the distal incision is extended until a normal intima appears. the distal perfusion is again restarted. During the now the onlay grafting is being performed. The onlay grafting is being performed bilaterally from the proximal edge toward the distal end. During this proximal anastomosis, the first proximal snare clamp is moved to the onlay anastomosis, and that lima was opened such that the proximal reperfusion is established. Then the onlay grafting with endarterectomy is being completed distally also with segmental clamping and distal perfusion in a beating heart. The anticoagulation, the post-operative anticoagulation parameters, the initial obviously through heparin infusion. Heparin infusion was started only after confirming hemostasis post-operatively. The infusion aimed to maintain an ACT of approximately 200 seconds. The level helps to prevent any early thrombus formation without excessively increasing the bleeding risk. From heparin to transition to oral anticoagulants, once the patient resumes oral intake, oral anticoagulation therapy was initiated, either with the warfarin along with the antiplatelet aspirin, 100 mg per day. Reasons for a dual therapy: the goal was to prevent thrombosis within the onlay graft, which are always prone to irregular inner surfaces, enlarged lumen, and also the turbulence in the blood flow. These factors increases of thrombogenicity, which is very common in early post-operative phase. But once the heparin infusion was stopped, when the INR value achieved, reflecting the anticoagulant effect of warfarin, which the INR when approximately reaches up to 2, the INR level is generally considered therapeutic for preventing any thromboembolic events post-operative period. During duration of warfarin therapy, warfarin was continued until the luminal remodeling was confirmed either by the coronary angio or CT. Specific criteria for discontinuations were designed as luminal equalization, that is the uniformity of the vessel diameter, the graft and the anastomotic host vessels, along with the smoothing of the inner surface with the resolution of the irregularity of the vessel wall. Typical duration was 3 to 6 months post-operatively, depending on individual healing and imaging results. Long-term antiplatelet therapy. After discontinuing warfarin, aspirin 100 mg per day was continued for lifelong as maintenance therapy. Aspirin helps to prevent the platelet aggregation and prevent the long-term graft occlusion. The criteria for follow-up. Angiographic measurements were taken in both the hospitals. In the Fukuoka hospital, the coronary angiography used for measurement, two projection views, RAO and LAO views were obtained. A 5 French catheter with a known diameter of 1.4 millimeters served as a calibration reference. The average cross-sectional area of the internal lumen was calculated using measured diameters. While in Kansai Medical University, the retrospective analysis using either a conventional coronary angio analyzed in the same way as the other hospital, or else the coronary CT was using a particular software. This software automatically detects the lumen contours and central axis. The inner diameters and areas were automatically measured. The measurements were taken from 5 specific segments of the onlay anastomosis and 1 graft point. These points will be depicted in the next picture. The point G, which is just before the anastomosis in the distal part of the graft, point 1, 2, 3, 4, 5 are at different portion. Point 1 is native coronary artery proximal to the anastomosis. Point 2 is a little far, that is proximal onlay segment. Point 3 is exactly at the center of the onlay segment. Point 4 is the distal onlay segment. Point 5 is the distal native coronary artery distal to the anastomosis. If point 1 was stenotic or occluded, a normal proximal segment of the coronary artery was measured instead. Point 1 and 5 were designated as reference, that is fixed points. The purpose was to estimate a standard coronary area for comparison to serve as boundaries for interpreting the onlay segment condition. This is the picture depicting the point G, point 1, point 2, point 3, point 4. The measurement of the diameters and areas of all the 5 segments of the target coronary artery and graft was obtained in 2 months follow-up period, and in the 91 months follow-up period, the area is shown in both the pictures. If a gradual decrease in coronary area was observed from point 1 to point 5 and points 2 to 3 and 4 were evenly spaced between 1 and 5, then the expected normal coronary area for point 2 to 4 was interpolated based on 1 and 5. This allowed comparison of the actual measured areas with an estimated normal to evaluate whether the onlay graft achieved luminal restoration, stability, or deterioration over time. Measurements were taken during the early post-operative period, just immediately after the surgery, and long follow-up period to assess any long-term changes. In long-term changes, it was evaluated the coronary artery area, the onlay graft durability, and the degree of remodeling and restenosis at the anastomotic site. Patients were excluded from angiographic follow-up if they had developed any comorbidities during the procedure, either in case of renal insufficiency or contrast medium allergy or patient refusal. Statistical analysis and result. Continuous variables were presented as mean standard deviation. The cumulative survival rate was calculated using the Kaplan-Meier's method of analysis. All data were analyzed using the parametric analysis of variance conducted in that particular software. Average number of anastomosis per patient received average number of 3.2 plus minus 1.1. The range of the number of the anastomosis are 1 to 7. Total onlay grafts performed were 127 coronary arteries. Among the 127, 43 were with coronary endarterectomy and 84 were without coronary endarterectomy. The coronary endarterectomy 43 patients, among them the 4 were involved in the old stent removal also. Simultaneously, multivessel onlay grafting. Two vessels onlay grafting in a same patient were for 14 patients, while all the 3 vessels onlay were done for 1 patient. The comparison between the early angiographic outcome and long-term angiographic outcome. The number of the patients evaluated early were 93. On average 1.7 plus minus 1.4 months post-op, that typically range from 1 to 7 months the follow-up was done. The early patency rate showed a considerable 98.1%. That is 102 out of 104 only anastomosis were patent. Well, in long term also, the follow-up was done in 78 patients with 88 grafts. The long-term follow-up ranged from 6 months to 180 months. The long-term patency rate was also very remarkable of 96.6%, that is 85 out of 88 grafts. Graft occlusions and stenosis. 3 graft occlusions were observed during the course. 2 Lima to LED graft with coronary endarterectomy plus only anastomosis at 12 and 17 months were occluded, while 1 saphenous vein to PDA grafts with only anastomosis without coronary endarterectomy was found to occluded at 55 months. One case of significant stenosis, 50 to 70%, 5% stenosis at 0.3 of Lima to LED only, detected at 120 months post-op. The surgical results were published in tabular form. The only anastomosis was 127, among them 43 with coronary endarterectomy.
You said this. Go ahead.
Okay.
You already said this.
Yes, sir. The only sites and graft material used for left-sided coronaries, the LED was perfused with 72 Lima graft, while 10 radial, while 2 Lima grafts, while in circumflex were anastomosed with radial, 5 radial, 3 saphenous vein and 1 Lima graft. Total number was 10, while there was 1 composite graft of Rima radial to circumflex, while diagonal was perfused with gastroepiploic artery with 1 free gastroepiploic artery graft. While right coronary were perfused, the posterior descending or atrioventricular artery was perfused with 22 times, with gastroepiploic 12 times, saphenous vein 8 times, radial artery 2 times, while the terminal RCA, right coronary with PDA, was perfused in 6 number of cases, among them 4 was with saphenous vein, 2 were with radial, while only the RCA was perfused with in 4 number of times with saphenous vein, all the saphenous vein graft. So the sites were LED 33 numbers, diagonal coronary endarterectomy sites where most of the time it was LED 33 numbers with 1 diagonal, 1 circumflex, 2 RCA and 6 PDA. Follow-up duration, the excluding the operative deaths, were 106 patients. The average duration was 102.8 plus minus 52.4 months. The range is 6 to 17 months. The median follow-up was 107.5 months. The late death occurred in few cases, while in some cardiac cases like chronic heart failure, ventricular fibrillation in 1 case and sudden death in 1 case, the total number were 7. While the non-cardiac causes, there were 23 deaths, with 7 for carcinoma, 5 with pneumonia, 3 with sepsis, and 2 at the senile decay, mostly more than 80 years of age, while some other causes of abdominal aortic rupture, chronic renal failure, diabetes, and traffic accident causes few deaths. Only anastomosis area analysis, the early versus late. The data from 54 patients were available for paired comparison. The paired t-test was performed regarding the area changes at the only anastomosis between the early and late period of the surgery. The Lima, among the grafts, the 33 were Lima, 8 were radial artery, 6 were gastroepiploic, and 7 saphenous vein. In early post-op cases, it was seen the areas which at point 2, 3, and 4, which I already explained earlier, they were enlarged in early post-op cases. But in late post-op cases, there was significant area reduction. The paired t-test showed the p-value of less than 0.001 at 0.234, while the p-value is 0.014 at 0.2 and P less than 0.01 at points 3 and 4 for saphenous vein. While in late period findings, area at point 2 to 4 matched the standard coronary size. That is, in the late post-op period, there is significant area reduction, and the size of the vessel matched the native coronary size. It is achieved by the luminal equalization with the native artery. The long-term angiographic change of onlay anastomosis, the Lima and LAD onlay, 5.5 centimeter in length with coronary endarterectomy stent removal. The three pictures shown. One is first is 1 month, and then is 12 months, and then is 69 months follow-up. This follow-up shows the gradual decrease in size and luminal equalization of the onlay anastomosis, achieving the native coronary lumen. This left-hand side figure shows the radial artery to LAD onlay 3 centimeter with coronary endartered at 1 and 36 months. This left-sided black arrow indicates the onlay anastomosis at 1 month, while right-sided white arrows the same onlay anastomosis after 3 years. That is the late post-op follow-up. While in case of the same finding, we can find for gastroepiploic artery also 1 month and 6 months follow-up. We can see the change in the vessel size. This figure shows the saphenous vein to RCA graph. The RCA to even the RCA to PDA graph, the onlay of 5 centimeter with coronary endarterectomy at 1 month follow-up and 84 months follow-up. The RCA, the saphenous vein to RCA to PDA onlay graft, which the black and white arrows indicate the range of the onlay anastomosis, which significantly changes over a period of time. These two figures, both of them shows the areas at points 2, 3, and 4, which enlarged early after surgery and significantly reduced later. In both Lima and radial artery, this both graph shows at the point 2, 3, 4 in the x-axis, there is in the early post-op period, there is significantly enlargement of the size. While in later post-op, that is which is depicted with the red line, in the later period, the 2, 3, 4 both sizes significantly reduces and equalizes with the native coronary standard area that is depicted with the green line. Similarly, the same with thing observed with gastroepiploic artery and saphenous vein. Both of them shows an area at points 2, 3, and 4 enlarged in early after surgery, but it significantly reduces later. In late periods, areas in points 2, 3, 4 showed no significant difference between a standard coronary artery lumen area in each of the graft group. Among all the patients, 5 patients underwent for reintervention, 4 for the new lesions in coronary arteries, 1 for gastroepiploic artery occlusion. The reintervention free rate was 99.2%, 126 out of 127 patients. While 29 patients readmitted in the hospital, among them 12 were for cardiac causes, 17 were for non-cardiac causes. Among the reintervention, the total 5 number of patients underwent PCI. Among them 4 were new lesion in other coronary arteries, while 1 for the onlay graft occlusion, which is gastroepiploic artery. The other readmission causes were cardiac causes like PCI, heart failure, valvular heart disease, ischemic cardiomyopathy, arrhythmia, non-cardiac causes, which are distributed among 29 patients. The Kaplan-Meier estimated survival rates shows that the 95% confidence interval, if we consider about the 95% confidence interval, the Kaplan-Meier survival curve shows that the 1 year survival rate of 93.6%, 5 years of 79%, 10 years of 71.3%, 14 years for 56.1%, while 18 years for 48%. That is with the onlay anastomosis. The optical coherence tomography images of the anastomosis also supports the fact the onlay anastomosis at different size and time points were taken. Saphenous vein to right coronary artery to PDA. Images taken 3 months after onlay grafting with coronary endarterectomy. The left-hand side showed the images, while Lima to LED images taken 60 months after onlay grafting. The optical coherence tomography images of the center portion of the onlay anastomosis is depicted in both the picture. The neointima formation, the neointima layer smoothly covers the internal lumen of the onlay anastomosis in both cases. The coverage results in luminal smoothing, indicating a stable and healthy inner lining of the grafts over time. The discussion part. Now we will discuss about the outcomes. The recent meta-analysis and coronary endarterectomy have shown it is associated with higher operative mortality with a odds ratio at 1.69 to 1.86. And the coronary endart also associated early post-operative MI with a odds ratio of 3.34. However, if we forget about that early part, the mid and long-term survival is similar between the coronary endarterectomy plus CABG versus CABG alone after 1 year. So after 1 year, both equalizes. Also, the MI readmission rates are comparable even after 3 years of coronary endarterectomy. So early adverse outcomes, including mortality, are likely linked to the patient comorbidities. The coronary endart patients were too much fragile or frail during presentation itself, and associated risk factors are more on those patients rather than to blame the coronary endarterectomy technique alone. However, post-operative MI may be more related to the coronary endarterectomy procedure itself because it can induce the ischemia and thrombotic occlusion risks are more. Comparative results of coronary endart techniques. The Nishi et al. Suggested the open onlay grafting is superior to closed coronary endart in midterm graft patency and imaging, which are proved by the intravascular ultrasound results. Onlay technique is beneficial even for less experienced surgeon when ischemic area and time is minimized. Segmental clamp and distal perfusion technique as used in this study, it limits the ischemia zone, it enables the early proximal reperfusion, it also enhances the procedural safety for any novice surgeon. Onlay grafting outcome, the current study data, the onlay grafting with or without coronary endarterectomy in all coronary territories showed an acceptable operative mortality, high survival and patency rates, low reintervention rates, also the favorable and lasting remodeling of the anastomosis. The factors which are responsible for this long-term remodeling and patency, the Shimokawa et al. Suggested it showed that the favorable remodeling of the Lima to onlay to diffusely diseased LAD after 1 year, it shows the favorable results. Current study data is also supporting the same. The long-term angiographic changes reveal diameter remodeling stops. This remodeling process stops after reaching the native coronary size. So the luminal equalization is achieved with native coronary artery, and smoothing occurs over a period of time regardless of the graft type in all coronary territories. So long-term patency rate suggested 96.6%. The mechanism of remodeling, the Nishigawa et al. using the optical coherence tomography suggested the complete endothelialization of lima to LED only within 1 year post grafting. While Okada et al., they suggested the intimal regeneration is also evident as early as 42 days post-surgery. This neointima originates from the residual smooth muscle cells of the endarterectomized bed of LAD or any coronary vessels. This neointima may extend even up to to cover the graft lumen also. It can cover the lima graft itself. The hemodynamic forces and vascular response. The neoendothelium senses the wall shear stress acting on the endothelium horizontally along the bloodstream. The blood pressure which is exerting vertically to expand the wall in circumferential, and also this blood pressure stress is cyclic strain. So the flow dependent adaptation of wall shear stress was shown by the Kamiya and Togawa. In clinical setting, this blood flow increases with a technically enlarged lumen after the onlay procedure. So after intimal regeneration, increased shear stress on the endothelial cells helps to normalize the shear stress, leading to a decrease in the lumen diameter. So the internal pressure acts as a circumferential extension force on the onlay anastomosis portion. Wall thickness and vascular pressure adaptation. Hayashi and Naik, they shown that the vascular wall adapts to increasing pressure by thickening, which restores the circumferential wall stress to a normal value and optimize the stiffness. With the, as we all know, with the arterial graft, usually they already adapted to the arterial pressure, so that they doesn't require any thickening. While in case of vein grafts, the wall thickening due to the higher pressure post grafting occurs likely as the ordinary saphenous vein conduits. Owens et al. Suggested that the wall thickening in hypertensives attributed to smooth muscle cell hypertrophy rather than the proliferation of the endothelium. While Hyper and Eisenberg, they opined that the cyclic strain of the blood pressure does not induce the smooth muscle cell proliferation. Finally, the remodeling on onlay anastomosis definitely leads to the luminal equalization without the luminal stenosis. It also reduces the turbulence through the neointimal smoothening. It stabilizes the shear stress on the arterial wall, which minimizes the risk of intimal hyperplasia and long-term restenosis. This study answers the plus's concern, which was that whether the shrinking of the diameter, that is the remodeling, whether it continues in the long term or it stops after a certain period of time. But this study answers the question that the remodeling stabilizes after adapting to native coronary size. Onlay anastomosis stability observed in all coronary territories, either it's left side or right sided, with all type of the graft used, either it's vein or any artery. Onlay grafting show promise for long-term vascular health in patients with diffusely diseased coronary arteries. However, future studies needed to validate the finding, to validate the long-term superiority over multivessel PCI, refine techniques to reduce the intraoperative myocardial ischemia during the onlay anastomosis with coronary endarterectomy. The study has certain limitations. This study was actually small and retrospective study. It was conducted on only 2 centers. All the procedures were performed by the only one surgeon, and there were some patients who were lost to follow up. It has also got some statistical limitation. There is limited pair angiography dataset available. Only 54 patients had both early and late imagings for area comparison and statistical analysis. In the conclusion, we can say that onlay grafting with or without coronary endarterectomy provides a sustained anastomotic patency over a long term. It preserves the major coronary branches effectively. It is favorable for physiological remodeling of the anastomosis observed. The luminal equalization is definitely achieved, aligning the graft and native vessels diameters. It promotes the luminal smoothening, reducing the flow turbulence and risk of long-term complication in the coronary lumen.
You,
Thank you, sir.
Rajdeep,
Yes, sir.
you took a long time. Your diction needs to be improved. Okay. You have to practice
Yes,
talking. Secondly,
yes, sir.
you went on and on and on about this article. You should learn to take a gist or summarize it instead of reading the entire article and entire line by line. Okay. So
Yes,
these are two or three things that you should understand, because you've taken more than 1.5 hours for your presentation. All right.
yes,
So in the initial part, I wanted you to talk about the different techniques of anastomosis, the principle of coronary anastomosis, maintenance of the laminar flow. That you talked a whole lot of theory, but you should have put some diagrams which people would have understood much better. To achieve a laminar flow, it is important for the anastomosis to be done properly with a proper cobra hood, and the length, and also importance of the lie of the graft, and it should not be very much angulation, or it should not be too flat. That sort of the lie of the graft and the length of the graft as well. These are important issues when you are doing coronary anastomosis. And the important thing about the corners, both in the heel and at the toe, you have to have a 45, 90, and 45 stitches, so that there is radial force holding the graft onto the corners. That is very important to establish a laminar flow. You
yes,
could have talked about the two suture. Some people use a two suture technique, and when and how that is used, you could have done that a bit. Then the importance of the arteriotomy is very important when you're talking about coronary anastomosis. If you are doing an end to side with a cobra hood, the arteriotomy on the native vessel should be about 1.5 times the diameter of the native vessel. Whereas if you're doing a diamond shaped anastomosis, it should be slightly less than the diameter of the vessel, so that
yes,
there is nice hood formation, and there is the anastomosis does not splay or flatten out, so that the forward flow is obstructed. Now, the other things are, there are a few controversies about the onlay grafting, different techniques that are being used. I'll ask Rahul to quickly comment on this, and then Jayaraj sir can take over. Rahul?
Morning, sir.
Yeah.
Few comments about the size of the coronaries. I don't know if I missed it, but I think that was not mentioned, if I'm not wrong. That is one thing. Other thing is even when you talk about diffuse disease, how diffuse it is, because when you're talking about only anastomosis, if you're talking about a concentric plaque which is extensively extending along the length of the coronary, then we are essentially, that becomes a contraindication to do an onlay graft. So was this explained in the article? I'm not very sure. So a lot of things where, it was more of like a statistical data set rather than a surgical, intricate details. There's not much of detailing about how they would do it as a surgical, mm, uh, you know, just 1 minute, sir. So that is one point I wanted to mention, because, and the other thing is uh, the on pump and off pump. One more thing I wanted to ask Rajdeep was Anastomosis depends also on, you have to start from the uh, farther away, like especially now everybody is jumping up and down about minimally invasive. So when you do the
Yes, sir.
anastomosis, you would want to prefer to finish the anastomosis, which is the part of the anastomosis which is farther away from you. And then you finish that part, and when you come and finish the stitches and come, you end where the part which is closer to you. That's a very
Yes, sir.
important thing. Many of them follow when you, especially when you're doing something which is the vessel exposure may not be the best. So you would want to finish the farthest part initially, and then come to the closest part. This these are the couple of
That
things which.
in that matter, we used to start with the heel and then do a backhand suture onto the away from you, and then come to the toe, and then come towards you with forehand technique, and then I finish forehand technique midway. So that was what I was taught, how to do a coronary anastomosis. But I don't know. Many people
Yeah.
start with the forehand only and then go out onto the other side. And some people do it from the opposite side, wherein they take from outside in into the coronary artery. That is not a good option.
No, the other option a lot of people, especially Ramesh follows, is he takes a mattress on the heel, in
Yeah.
and out from the coronary. So all the stitches are according to the principle where it comes from, the conduit it's outside in and the coronary is inside out. So this is a very simple technique, especially for people who are just starting. So you are not compromising on the technique. All the bites on the coronary is inside out, like going to the coronary and coming out. And also you will finish the farthest portion first, and then come to the part which is closest to you. So that is one thing which is very useful, especially when you're doing sequential anastomosis.
Yes, sir.
So that is one thing. Yeah. So my only grouse on this is when you're talking about onlay patching. If the
Yes, sir.
coronary sizes are very small, I'm not very sure how it's going to be. How it's possible to do a onlay without an endarterectomy. So that's one point I wanted to make. Thank you, sir.
The one important thing is to know the distal end of the endarterectomy specimen. Where you have the delineation of the distal end. It should taper down like a rat tail, and then you gently ease it out of the coronary lumen and then take it out. So that is important to know, rather than sometimes if you're rough, you can rupture the plaque in between, and then it becomes like a straight cut end there. So then the distal flow is compromised.
Yes.
Yeah, like in the video what you showed, if you I think if you notice in the distal end, he is not removed the plaque completely. There is a lip of the plaque. So basically,
Mm.
what you need to do is you need to fix that plaque on the coronary so that the flow is into the true lumen. It's a very important point to remember. Like even if you are not targeting complete distal clearance and you have a lumen in the distal portion, you can actually just fix the plaque onto the coronary along with the stitches, so that the plaque, there is no dissection intra coronary. That's one more technique what many follow.
Sir, you have comments, sir?
No, in 1980s and 90s, we used to do a lot of endarterectomy of the right coronary artery, especially when it's a dominant right coronary artery and even the PDA is not graftable. We used to do actually a blind sort of endarterectomy by opening the right main before its bifurcation into the LAD and the continuation in the AV groove. And very often, as you said, nowadays, people don't prefer the close endarterectomy because of the problems. You don't get a complete spider-like thing, because you're gently doing dissection, slide pulling, breaks off, and the debris is left. and sometimes the main branches arising are closed. So what we used to do on the right side, actually, it used to be much more common on the right side, even though in your article, I think it's more common on the left side. Then Dudley Johnson started the long incision on the LAD and open endarterectomy and putting a saphenous vein graft, the long split and onlay patch. And they all actually had some problem with the proximal end. When a saphenous vein is open so much, and then it is put in an onlay patch, the flow at the proximal anastomosis sometimes get reduced and sometimes gets blocked. Then I think a lot of people started putting an onlay patch of saphenous vein on the long endarterectomy of the lady and put a lima in the middle of this saphenous vein patch. I think Praveen also used to do that, I think. I don't know whether still they are doing that onlay patch and reinforced by a lima graft, actually. Then
That was the controversy, sir, because
yeah.
earlier, the flow depends on the lumen of the graft. So even if you make a long anastomosis, the flow is not going to be more.
I'm not very convinced about this segmental clamping and distal perfusion. It looks a very complicated procedure to me. And in the anterior shoulder, it's of course incision more than 2 centimeters, and more than 2 centimeters, you said they prefer an open heart surgery. When you do open heart surgery for a protection, classically everybody does a antegrade as well as a retrograde cardioplegia. That sounds more feasible in open heart surgery rather than this segmental clamping by a snare and then changing the segmental clamp and the distal perfusion. It doesn't.
That itself will cause intimal damage.
I'm not sure actually. So why not do a simple protection by antegrade and retrograde cardioplegia and do long endarterectomy and do it with ease, That's all.
Okay, I think we have gone on too long today. Rajdeep, it was an extensive presentation.